So ask the patients to stand. Their wrist will be in extension. They will push the plunger down completely until the red light comes on. Once the red light comes on, we know that we have complete depression of the plunger. Again, we can change the amount of resistance there. So one exercise could be just loading and a hold for a period of seconds and then relax. Loading, hold for a period of seconds and relax. We can also have the patients load and slide so we get some movement of the upper extremity while it's loaded. This is an excellent way to use stress loading and also closed chain exercises for our patients with wrist injuries. They have to have sufficient wrist extension in order to provide the pressure over the plunger. However, it also can be an assistive device used to increase wrist extension in those patients who have that limitation. Again, our exercise prescription will be based on their stage of healing, as we described earlier in the connective tissue physiology section. Those patients who are in the acute stage, certainly they would not be candidates for this type of exercise because the tissue is not ready to accept this amount of load or stress. In the tissue remodeling and maturation phase would be an excellent time to institute manual resistive and resistive exercises as well as closed chain exercises as described. Again, your frequency, intensity, and duration will be determined by your patient's healing process, the surgical procedure if it's been provided to the patient, and also their tolerance for the exercises. The next chapter in our series is Carpal Instabilities. Please refer to slide 46, in which I've listed the common carpal instability descriptions. You'll see a list starting with CID, CIND, DISI, VISI, and DRUG. We will describe each of these instabilities, talk about their implications in terms of patient care, and how we can impact these as therapists and their long-term outcomes. Looking at CID as carpal instability dissociative, these are describing the instabilities that occur between the individual carpals, such as a scapholunate dissociation is one good example. The CIND, or carpal instability non-dissociative, is an instability between the rows of carpals, between the proximal and distal row of carpals, as opposed to each of the individual carpal bones as we would describe in CID. These carpal instabilities can occur as a consequence to some trauma that occurs to the wrist joint. This could be a fall on an outstretched hand, could be subsequent to a scaphoid fracture, a Colles fracture, any kind of significant injury to the wrist joint. In those cases, it is important for us to look at the wrist and the potential for carpal instability and how we might be able to identify that if it hasn't been recognized in those patients to this point. Suffice it to say, if we have patients who come in following distal radial fracture, scaphoid fracture, lunate fracture, and the like, that we should look at these patients as potential carpal instability type patients.